Good afternoon, everyone. Thank you for joining us for our Thursday afternoon webinar. I'm Melinda Bikini, Director of Patient Services with the Cholangiocarcinoma Foundation. And today I am pleased that we have Dr. Pashtun Qazi joining us. Dr. Qazi is an oncologist and researcher at Weill Cornell Medicine and New York Presbyterian Hospital. He focuses on treating patients with GI cancers and the treatment of patients with novel drugs, early phase clinical trials. At Weill Cornell Medicine, Dr. Qazi additionally serves as the Director of Colorectal Cancer Research, as well as Precision Medicine Director for Liquid Biopsy Research at the Englander Institute of Precision Medicine. And there is a whole lot of other information on his bio, but I am going to turn the presentation over to Dr. Qazi and remind everyone that if you have questions, please put them in the chat or the Q&A box, and we will answer them at the end of the session. And also a reminder to please keep them general questions, as Dr. Qazi will not be able to answer any personal medical questions. Thank you, Dr. Qazi, for being here.
So much for the kind opportunity. What I was going to focus today on, there's of course a lot going on in the world of cholangiocarcinoma as well as precision medicine. What I wanted to focus on is the story of how liquid biopsies, and I'll explain more what this term means as we go along, is helping with precision medicine for patients with cancer. In particular, we'll talk about cholangiocarcinoma. And I would say for me, both, taking care of patients with cholangiocarcinoma as well as how liquid biopsies has helped in the precision medicine has been serendipitous in the sense that it were the patients who were asking us if we could do something that's not invasive as a tissue biopsy that could potentially serve the same purpose, or anything that's non invasive, that prompted us to look at options that led to where we are today in terms of the research and kind of going from the patient side of the story to the lab and research, and then again bringing it back to the patients. So my contact information as well as Twitter and Facebook handle are listed there. Again, would make sure that we have time today for Q&A as much as possible today. It's I learn from everyone as much as it's an opportunity to exchange information. The other questions as well down the line, we can continue to engage on social media for questions as mentioned earlier. So these are our disclosures for any scientific presentation or webinars. Because of our expertise in liquid biopsies and ctDNA and precision medicine testing, there are companies who are either manufacturers of some of these liquid biopsies or some of these other companies for which we are sought for consultancy and advisory board. All these disclosures are available in public domain, as well as at ASCO's, as well as Cornell's website. And of course, today we'll be talking about both on-label as well as off-label use of this exciting area of research in clinical care called liquid biopsies. So I wanted to kind of highlight three main things for the purpose of the webinar. I wanted to kind of show how liquid biopsies is helping in precision medicine, and what does precision medicine broadly mean when people use this term. It's important to realize there are types of liquid biopsies. When somebody says, I want a liquid biopsy test, it depends on what is the question that's being asked in terms of what exact tumor type. There are some assays that are meant for only certain types of cancers. There are some assays that are only meant for certain clinical situations. We'll explain what that means. And then, of course, the liquid biopsies are moving up the ladder of a journey of a patient with cancer, even into screening. And it has implications, especially for a disease like cholangiocarcinoma, where we have all these early programs for screening, as well as in some cases where diagnosis becomes very difficult. It's also not just relevant for patients with advanced or metastatic cancer where it has already spread, but a lot of the patients who, for example, the cholangiocarcinoma community is more aware about this, that there are certain diseases that are risk factors for cholangiocarcinoma. Example, something called PSC, or primary sclerosing cholangitis, where there is scar tissue developing and then the plumbing of the bile ducts that eventually can lead to cholangiocarcinoma. And these kind of patients, there's still an unmet need, or how we diagnose. There are multiple procedures, ERCPs, and things that are being done. And it's, of course, very invasive and frustrating when diagnosis is not possible because of lack of tissue. So, ASCO, which is our annual conference in oncology, last year had a whole session that was titled ctDNA, the Dawn of a New Era. Again, this is available online as well for anybody who wants to look at it in more detail. And there was a lot of chatter and discussion when this was presented. We had the opportunity of chairing the session, and within the session there were different tumor types. So the liquid biopsy, while we're talking about cholangiocarcinoma today, it is something that's having an impact across all solid tumors. In so many ways that at a lot of these meetings now there are dedicated sessions, and a lot of what we're learning from one tumor we're applying to other tumor types. So when you talk about liquid biopsies or focus about liquid biopsies in the context of cholangiocarcinoma, some of the data that's out there right now is broadly in other solid tumors, but it's still relevant to how it may apply for cholangiocarcinoma as well. There's also a term which is called agnostic. A lot of the treatments are becoming agnostic, meaning that doesn't matter what type of cancer you have, doesn't matter what kind of tumor you have, as long as you have the specific lock for which that might be a key that could be prescribed. One example in the context of cholangiocarcinoma, actually several examples. Most recently, if somebody with cholangiocarcinoma has something called a BRAF V600E mutation, there are BRAF inhibitors that used to be that it was only approved for melanoma, then it got approved for colon cancer, then it got approved for thyroid cancer, and you had to have a trial for every single type of cancer for it to get approved. Recently, there are at least 6 or 7 agnostic approvals, immunotherapy for something called microsatellite instability high or mismatch repair deficient cancers was the first to set the precedence, and then subsequently it has now been approved for some fusions that are positive. We'll go through some examples, and then with BRAF being one more addition, the newest kid in the block. So in the context of that, finding those mutations is important, because then you can get access to these precision medicine-based therapies. Now, this cartoon kind of illustrates, broadly speaking, when people talk about liquid biopsies, the broad term could mean a lot of things. In the clinic, we're talking about circulating tumor DNA, but it also could be circulating tumor cells. As one of my colleagues calls it, there's a lot of tumor trash that's detectable in the bloodstream. Some of it is coming actively into the bloodstream as the cancer is trying to spread. Other is just passively being shed off into the circulation, and the DNA of the tumor is something that's detectable, and that's why the term circulating tumor DNA. Interestingly, a lot of this actually originated in the world of prenatal diagnosis and pregnancy. Some of these tests and liquid biopsies that we're using for tumor right now have been around in development for pregnancy and neonatal related testing for over a decade, in fact, even more, because even in pregnancy, there's the question of, for example, amniotic fluid sampling, or how do we know if there is any genetic abnormality in somebody who's having a high-risk pregnancy, or nowadays you can do a blood test as early as first trimester of pregnancy to know the sex of the unborn child, and or if there are any genetic abnormalities. That's because as the fetus or the unborn child is growing in the mom's womb, it's shedding its fetal DNA into the circulation. Similarly, if you think about it, the cancer is also a foreign being in the person. It is also shedding its DNA. So some of the technology or companies that are now available and doing circulating tumor DNA or liquid biopsies are the same vendors who actually have been doing circulating fetal DNA for years and years. So important to realize that liquid biopsies nowadays is not just giving you information about the mutations or DNA, it's also giving you information about something called MSI, for which immunotherapy is now an option. It's giving you information regarding something called tumor mutation burden. There are different lenses with which these tests are looking at the same question. And simplistically, these are tests that are looking for a needle in the haystack. The blood sample that's sent in these different tubes it's supposed to have your own DNA. It should not have any tumor DNA. So anything above 0 is abnormal when it comes to tumor DNA. So that's where some of the numbers get confusing when they say 0.2%, 0.4%, or 1% of some of these liquid biopsy reports. What that means is, 100% of that blood sample should just be your own DNA. If there's any detectable tumor DNA, which could be as low as decimal points, that's concerning. That's coming from the cancer. So the actual number, while of course a very large number is concerning and a lower number is reassuring, and the trends in the same patient can also be now used to assess response to therapy. So the fact that it's a non-invasive test, it also allows for response assessment, a new indication that now recently got approval as well from some of these companies. As again shown in this cartoon, these liquid biopsies are having an impact in all phases of a journey of a patient with cancer. There's some editorials and essays that we wrote that are available through the ASCO Daily News website, if you get a chance to read more about them. But a lot of these tests, they started off in patients with stage 4 or metastatic cancer when the cancer was everywhere in their body, and we were trying to figure out, what does the cancer have? That's how a lot of these liquid biopsies started off their journey. And then to targeted therapy, sometimes, we block these highways for the cancer to grow, but then the cancer starts having detours around them. So these acquired resistance mechanism is also something you can see as the cancer is mutating or evolving. And then more recently, to see if there's any leftover cancer behind after surgery, who should be getting, in the future, one could be more smart about, rather than giving chemotherapy to everybody as mop up after surgery. Potentially one future potential as these tests get better could be to spare the toxicity of chemotherapy to somebody who doesn't need it, and then give it to somebody who or even escalate therapy to somebody who may have leftover cancer behind. And then, as I said, nowadays it's also moving into diagnosis as well. So broadly speaking, before we talk more about cholangiocarcinoma, it's important to realize there are different types of liquid biopsies. So a lot of these tests that were been available for advanced or metastatic cancers, they don't care what type of cancer you have. You can use it for cholangiocarcinoma, you can use it for colon cancer, lung cancer. These are what we call next generation sequencing based panels or NGS based panels. All it means is these are broad tests that look at all kinds of DNA in terms of mutations, spelling mistakes, fusions. They also look at something called microsatellite instability, see who is a candidate for immunotherapy, and kind of go from there. And then some of these newer assays are also looking at kind of diving deeper to find out if there's any leftover cancer left behind, where a piece of the tissue is sent to them. They make a barcode simplistically of the tumor for that person, for that tumor at that instant in time. And they look for the same barcode in the blood of the person to see if there's any leftover cancer. So that can help in terms of decide in terms of who can be a candidate for additional therapy. This cartoon also simplistically shows the same thing, that there are some tests that don't require the presence of tissue. You don't need to send them any tissue or cancer piece. You just need to send them a blood sample. Whereas others, you have to send them a piece of the cancer. They make the barcode for you, and then you look for the same barcode in the blood. As the name suggests, tumor-informed platforms versus tumor-agnostic or plasma-only platforms. There are some articles that are good to know, to understand that it's not a one-stop shop and answer for everything. It has its limitations. Some of these guidelines, which are a few years ago, talk about the fact that it's not yet ready. But if you look at any conference, there are hundreds of abstracts nowadays looking at all these things. And these are not my slides, but other people in other cancers are talking about. These are things that are ready for prime time. And again, it depends on the question you're asking. In a journey of a patient with cancer, in the setting of metastatic disease or advanced disease, in terms of assessing or diagnosing or deciding who to give what therapy to, these tests are, there are many platforms that are available. It's more so that earlier phases, in terms of any leftover cancer left behind, or in the early detection phases, there are tests that are now in trials, and some of them are commercially available that need more time. But in our day-to-day practice, at least for our clinic, we use liquid biopsies at diagnosis because also here the advantage is the turnaround time as well. We get results back within 6 to 7 days to know how one person's cholangiocarcinoma is different than another. Because sometimes, tissue, even if available, can take 2 to 3 weeks for some of these results to come back, and sometimes even longer. And I'll show you some data. At least a third of the time, you get an answer that the biopsy or the sample that was sent is not good enough, that they need more. So, a lot of the data that you'll see in liquid biopsies and these white papers are in colorectal cancer, but a lot of this is applicable to not just cholangiocarcinoma, but the whole field of liquid biopsy as a whole. And then also, with more targeted therapies evolving, there are patients who are on one therapy, like, with cholangiocarcinoma, one of the first target therapy, of which now there are many target therapies, something called FGFR to fusion inhibitors. There are at least 7 or 8 that I know of that are in different phases of trials, and every time you look around, there's another company with their own FGFR inhibitor, several of which that are FDA approved already and in guidelines. So patients with FGFR fusion positive cholangiocarcinoma, for example, can have multiple treatments, one after the other, where you can imagine that, if the same tumor has been treated for years with different therapies, a biopsy that's from 4 or 5 years ago is probably not representative of what's going on right now. Often what happens is, either the treatment is eradicating the sensitive clones and the resistant clones, just like the Darwin survival of the fittest, they outgrow, or these clones were there to begin with. It's just a matter of time that they just appeared. With more sensitive tests, I think it's more the former, that these are truly acquired resistance mechanisms. So, for example, for patients who have FGFR fusions, they develop mutations as a mechanism of blocking the key and lock of the same drugs that they can't fit in anymore. And there are newer drugs that would work when the previous drug stops working. Again, this cartoon again illustrates the same concept that, sometimes these are truly acquired mechanisms of resistance, where you have to think of these cancer not as nodules with different sizes. These are different colored, they're all from the same parent, but then they evolve and change over time. That makes it different over time. And especially with targeted therapy, not so much to chemotherapy, I would say after any kind of targeted therapy like HER2, FGFR, or immunotherapy, these cancers can evolve and change and are different. And sometimes, just not messing with the beehive and doing something non-targeted, these cancers can also simplistically lose these mechanism of resistance to kind of reset the clock back and allow for resensitization. So again, if you're talking about, monitoring for this, it's not safe, feasible, or practical. And from a patient standpoint, you can't just be having tissue biopsies every couple of months or, every so often if you're talking about years of treatment. Whereas a liquid biopsy is a non-invasive blood draw. It's a misnomer. There's no biopsy being performed. It's just a simple blood draw. So that can be repeated at different instances in time, at diagnosis at least, at times when decisions are being made when the cancer is getting worse. And there's some data to show that this might even predate the cancer getting worse on scan. So you could use it as an early marker of potentially response or worsening of cancer. Again, can it replace tissue biopsies? This is an example of a patient of mine with BRAF cancer that at multiple time points, you can see in liquid biopsy, we can see all the colors, but tissue may fail multiple times. You can use it to determine how colorful these cancers are, meaning they have a high number of mutations. And this is also something for which now immunotherapy is approved in terms of tumor mutation burden. It's important to realize that the liquid tumor mutation burden is different in different cancers. You can see how cholangiocarcinoma compares to lung cancer or endometrial cancer. So the same test can be used, but there are probably different cutoffs that are needed, and harmonization between liquid and tissue, and even within tissue or liquid, different cancers may have different cutoffs. And then, there are guideline approved markers, but then there's this area of agnostic approvals in GI cancers, and particularly cholangiocarcinoma, where there are more options, not just for the bucket for which you have an approval or label like IDH or FGFR, but for MSI, TMB, you can add RET to the equation, BRAF. If you find these, you can prescribe drugs to these patients, including The biggest home run, is MSI high, something for which immunotherapy was the first thing agnostically approved, for which, there are multiple drugs that are available. HER2 is probably the next agnostic marker in the NCCN guidelines for cholangiocarcinoma. There's already one approved at ASCO, which was our annual cancer a few weeks ago. There were at least 2 different anti-HER2 drugs, one something called a bispecific antibody that is showing promise. And compared to chemotherapy that only works for a few months, some of these patients who had seen multiple types of chemotherapy and stuff over the years, they still were on these therapies and alive and with minimal side effects for durable responses. So this is something that if you find it, and interestingly, it's something that's more seen in gallbladder cancer than extrahepatic cancers, as opposed to intrahepatic or cancers within the plumbing per se. There's a lot of hesitancy regarding fusions being detectable on liquid biopsy. I'll show you some more data as to what the issue is. Fusions are large gene rearrangements, so sometimes liquid biopsy is not the best test for that. However, if you do pick up a fusion, there's no false positive, meaning that's real. If you have a test report that's negative for fusion, it's important to realize that you could be still sitting on a fusion, that you should consider a tissue test and do DNA and something called RNA. But I think the bigger issue is this slide it sums up the bigger problem at large. A lot of these drugs and treatments I talked to you about, immunotherapy for MSI high, immunotherapy for TMB high, FGFR fusion inhibitors, of which there are 3 different ones for cholangiocarcinoma. As a poster child, you have IDH inhibitors. If you kind of roll the dice 30 to 55% of the time, depending on how conservative or optimistic you want to be, pretty much, 1 in every 3 or 1 in every other patient with cholangiocarcinoma, you'll probably find something actionable. And that's true, and it's becoming a lot more for other cancers as well, like breast cancer, lung cancer, colorectal cancer is also something new with more markers and drugs and treatments being different. But then in real world, depending on the tumor type, and especially with cholangiocarcinoma, the diagnosis often is based on something called an endoscopic biopsy or ERCP. You might have seen the term. They get us barely enough tissue to make a diagnosis. And often, as patients with cholangiocarcinoma and caregivers taking care of patients with cholangiocarcinoma, it's not, it's the norm that often it's multiple ERCPs or at least a few scopes or biopsies, even to get to a diagnosis. So it's hard as is to even get enough information to make a diagnosis, let alone doing hundreds of tests. So often, this fails at least a third of the time. If you look at the real world data for cancers of the pancreas or cholangiocarcinoma or things that are in that territory, because of how the biopsies are done. So that's a big problem, because if you don't know, what type of options there are besides genetic chemotherapy, I think that's a missed opportunity. Because, while immunotherapy with durvalumab and something called pembrolizumab is now approved in addition to the generic Gemcis chemo that's given to anybody and everybody with cholangiocarcinoma, some patients, of course, derive immense benefit, but the fair majority derive, minimal or modest benefit. So the magic pretty much lies, in my opinion, in these, target therapies. So you need to be able to identify all these patients, or simplistically be able to hit these loose ball for home runs. So while advances are not coming for all patients with all types of cancers, advances are coming for subsets of subsets. So you have to be able to identify all these subsets, and these are drugs that are more like lock and key. If the lock is not present, the key is useless, no matter how shiny or expensive it is. So if you find it, it's 100%. If you don't find it, it doesn't do anything. So how do we, complete genetic testing for patients with these malignancies? The liquid biopsies here is able to fill this void. And, while we think about cholangiocarcinoma as a target-rich disease, you'll see this name often coined. It's important to realize, while we are talking about cancer arising in the plumbing of the liver, with the cancers within the liver, as intrahepatic, cancers outside the liver, as extrahepatic, depending on the tubing, and then you have the gallbladder cancer. Even though these cartoons kind of talk about as all these cancers are the same, they are not. They are entirely different beasts altogether. And If you, like I said, do testing in every single patient with cholangiocarcinoma, you will find FGFR2 15-20% of the time. Again, intrahepatic is where you find them. All comers is about 4%. In fact, gallbladder cancer and extrahepatic cholangiocarcinoma, FGFR2 is a very rare event. Same goes with IDH1 mutations, for which you have a pill now that's approved. That's again 15-20% of intrahepatic cholangiocarcinoma, meaning the plumbing inside the liver. HER2, as I mentioned earlier, is more so a gallbladder cancer phenomenon. In fact, some of the gallbladder cancers have rates of HER2 positivity even higher than some of the breast cancer and stomach cancer and some of the other common cancer where these drugs have approvals and are used more often. BRAF, as I mentioned, it was in the guidelines already, but now you have an agnostic approval of two BRAF and MEK inhibitor therapies. We're talking about mismatched repair for immunotherapy. You have TMB high, and then already, because there are more options that are becoming available with BRCA, the breast cancer gene, it's estimated anywhere from 5 to 25% of the time that you will find something that's BRCA or breast cancer gene or DNA repair family related in patients with cholangiocarcinoma. So liquid is not meant to replace tissue testing, but it will help fill the void of finding all these relevant mutation or fusion targets. And also, one thing to realize, it does not replace the question of germline testing to see if something is running in the family. So in a perfect world, it should be universal testing tissue and tissue on a panel-based platform, and ideally with something called an RNA in it. But then liquid, you could consider something called a plasma first approach or blood first, meaning you do a blood liquid biopsy first and see if you get the answer. And if you don't, then you do the tissue later, or you do it at the same time, as long as we can get the cost covered by the insurance, where you can get the rapid readout within days of even before the biopsy. So, I see in a center with good imaging, like or as a good CT scan or MRI, patients may already have a diagnosis of cholangiocarcinoma before even the actual biopsy is arranged. So we've had cases, where I saw the patient as the biopsy was being arranged. So let alone having the piece of tissue to send for genetic testing, we've had results of liquid biopsy be available before even the actual biopsy, before even the diagnosis of cholangiocarcinoma or adenocarcinoma pathology report came by, before which you can even order testing. So, it can really help expedite diagnosis and tests. And then the other bucket of patients with cholangiocarcinoma often start their journey with is this, terrifying diagnosis of something called cancer of unknown primary. You are being told that you definitely have cancer. We just don't know where it started. The fancy medical term for it is CUP, which is cancer of unknown primary, meaning that, like I said, you have cancer, but we don't know where it started. Often patients who have a liver mass or something in the liver and this diagnosis of CUP, surprisingly, 2/3 of them end up being cholangiocarcinoma. And some of these diagnoses findings, so for example, if I have a patient with CUP who has an FGFR2 fusion with a liver mass or an IDH1 mutation, for example, that seals the diagnosis of cholangiocarcinoma. The biggest favor you can do to a patient with CUP is help them at least find a diagnosis. Otherwise, with the diagnosis of CUP, you can't prescribe them anything. Even if you find something like, if you find an IDH1 mutation or FGFR2, but if you still keep calling it a CUP, the insurance only allows you to do just plain generic chemotherapy. You can't give them any of these therapies. So, or even enroll in them in some of these trials. Some trials are smart where they're allowing patients with CUP with particular findings enroll, because it's more about, like I said, finding the lock and key as opposed to having a diagnosis. But having a diagnosis code is important for trials. It's also important from a clinical care standpoint, because everything is allowed or approved by insurance or Medicare or guidelines based on, you'll find, 2 or 3 different FGFR inhibitors for cholangiocarcinoma in the cholangiocarcinoma guidelines, but you won't find a single drug approved for patients with cancer of unknown primary. So this is not only helpful in finding the drugs when you already have the diagnosis, but it can also be a diagnosis alerting finding. And we've shown some of this work published even years ago, like back in 2018. Now it's almost 5 years that we using any kind of liquid biopsy platforms. There are several of them available that you are able to meaningfully identify these things for which there are drugs that are available in guidelines or through FDA or through Medicare or through insurance, or you can find the right trial for them. And surprisingly, when people say we can't find fusions on liquid, it's interesting. If you look at the real world data, in some of the work that we did with liquid and tissue combined with one particular company, and this was presented again years ago at Cholangiocarcinoma Foundation conference as well as at ASCO GI, we actually found more liquid detected on fusion. So again, that doesn't mean liquid is better. It's just that in the real world, liquid was often completed. So you had more number of people who actually had a liquid completed that led to a diagnosis of FGFR2 fusion. So if you do find them, these are real events. If you don't find them, that's where the tissue in some ways is lagging behind. So again, not meant to replace tissue, but as an adjunct. So when you do find these fusions or mutations or V600E or HER2, again, these were conservative estimates. We just picked the, top 6, 7, 8 for which there are drugs, for which there are trials, not the ones that may be promising, but you have nothing to offer. And again, when you do find these are very heartening experiences. This one of our first experiences of finding a HER2 in a patient with cholangiocarcinoma was somebody who was not even trial eligible because the liver numbers were so high that the recommendation was to, either consider a different chemo or maybe even do hospice, where we stumbled upon a HER2 amplification and the patient was on HER2 therapy for years to come. This is another patient of mine where her cancer in the bloodstream disappeared, and she presented with confusion to the emergency room. This is just from a few months ago. And interestingly, we didn't find any cancer in the rest of the body, but in the brain, this is an MRI of the brain, all the white spots that you were seeing, it's all cancer, and there were hundreds of spots. And it's not because the drug wasn't working. So that when we repeated the testing on the tissue from her surgery several months ago, the tumor still was HER2 positive. Sometimes these tumors are sneaky. They can become HER2 negative, knowing that you are giving them HER2 stopping therapy. They can actually lose the HER2. So just like a spaceship landing on a planet, now there is nothing receptor-wise for which the drug lingers on. So in this case, it wasn't the issue that the HER2 was lost. It's just that certain drugs don't enter the fortress, which is the blood-brain barrier. The nature has made like a barrier, simplistically speaking, where a lot of the drugs and toxins are not able to penetrate. The only reason why the cancer was able to find a place as a sanctuary was the brain. And we were able to, give this other drug, which has blood-brain barrier penetration. And just after one round, you can see all these hundreds of metastases just disappeared. I just literally saw this lady 2 days ago for her, I'm losing count. It was the 5th round or 6th round of the same drug, and she's out of the hospital. She would have been dead within days based on, even, with the hundreds of metastases, they were talking about, even whole brain, they thought would be just too morbid because it's just too much. And for that person to be our patient, have we cured her? No. But as she alive and well and has a decent quality of life and has this kind of outcome, it's all about, precision medicine and finding this. FGFR fusion, is like I said, many cholangiocarcinoma foundations and the guidelines and the trials are all about this new target. Not necessarily new, it's now you have so many drugs, but we published on this several years ago too, that patients, when you do find these targets, there's so many drugs and options that a lot of these patients, the x-axis here is months, and this was published years ago, and these patients had years of therapy subsequently. One of my patients from an unresectable, untreated situation went on to get a transplant and still doing well, like more than 5 years out. So so those are things that for these rare, I wouldn't say they're rare, I would say they're uncommon events, but you have to be able to find all these people. And like I said, you develop these new resistance mutations or these new highways for the cancer for the drug to stop working, but then they can be fleeting, they can disappear over time. So you can then move on to the next pill or the next target. And now there are so many companies with different drugs. Just a few weeks ago at ASCO, you have pemigatinib initially, now you have futibatinib. There's other drugs that still are looking for a name. That are overcoming some of these resistance mechanisms. So there's some elegant work from our colleagues where it has shown that even in the same person, the same cancer, the tissue biopsy of different parts of the liver showed different mutations, but liquid is capturing the whole heterogeneity, so something that the tissue can't fill. The next few minutes, I want to make sure we're mindful of time. I wanted to also highlight that the ctDNA has a very quick half-life, meaning that as soon as you start something that's working, it should disappear very quickly over time. And again, this is an agnostic concept, meaning that if you can detect ctDNA at baseline, you can repeat the tests as early as a few weeks into therapy. One of our patients with MSI-high cholangiocarcinoma within weeks had disappearance of the ctDNA. So that predates the scans by several months. And again, persistence of DNA or increase is never a good thing. And then across many other tumor types, not just cholangiocarcinoma, colorectal cancer, pancreas cancer, lung cancer. And again, it doesn't matter which platform. This is using a tumor-informed platform. This is using a plasma-only platform. If you clear kinetics, meaning that, if you clear simplistically ctDNA, those are patients that do the best. If the ctDNA is rising or persisting, not a good sign. A fall, again, we don't know whether it's 10%, 20%, 50%. A fall is good. So again, one new area of application, liquid biopsy. And then again, this new area about how do we pick up something called minimal residual disease, meaning leftover cancer that the scans don't detect, but somebody may have cancer left inside their body. Right now, arbitrarily, we give everybody mop-up chemo. Can we be more smart about giving the chemo to somebody who's here in this green line, who's not cured, versus sparing the toxicity? So again, these are things for which there are not just tests, but also depends on the shedding. Shedding of cholangiocarcinoma is higher than some of the other cancers. So it is a good cancer, but it also depends on where the cancer is. Some patients with lung-only metastases, for example, they shed very little ctDNA, so the same test could be falsely negative. So it's not just the test, it's not just the cancer, even the same person, the same cancer in different parts of the body can shed different types of cancer as shown here in this cartoon. So we're talking about the unseen cancer that the imaging may not detect, but remember, even ctDNA can also have its limits of detection, so you could have false negatives for anybody who, and again, some of the data is showing that it's picking up cancer 9 to 12 months before a scan is picking up. So again, not meant to replace the current imaging modalities, but something as an adjunct. And then you have to realize that immediate post-op, there's a lot of background noise. You're looking for a needle in the haystack. You could have a false negative signal if you did the assay too soon. So a positive is a positive, but a negative, you could have a false negative signal, and the detection gets better as the healing gets better over time. And again, some of this data has been replicated in cholangiocarcinoma and the conferences. So simplistically, you're looking for the needle in the haystack. In the immediate post-operative period, things to remember is there's a bigger haystack that could affect the detectability of the assay. And then I like to compare this study often. We're not talking about my experience or your experience or this hospital, that hospital. In Japan, they did a prospective study. This is published, something called the GI screen study versus the Godzilla. They were trying to, again, increase opportunities for precision medicine for their patients with GI cancers. And they said, let's do tissue testing and we'll do it. We'll get good biopsies. We'll do it in everybody. And what they found, and then they started doing liquid as well. In their study with across GI tumors, at least 10% of the time tissue failed. Now, again, remember, this is a trial situation where they already know that somebody has cancer. So they're going to do their better job. Real world, things are worse. So it's underestimating the problem where tissue is not sufficient. Liquid biopsy, as you can see, only failed 0.1% of the time, unless you broke the tube and didn't collect the tube right. Again, those things still can happen. It's hard to imagine where a liquid biopsy will not be able to be completed. And that's the other thing, the turnaround time. If you compare the turnaround time, again, this is the trial situation. I'm not talking about that my hospital is better than your hospital or the community is, worse than academics, or if you talk to people at these ivory towers, they say, oh, we always get results back within 2 weeks. That's not necessarily entirely true. If you actually look at the actual data, it's hard to even get a result back within a month time. And then they showed that even in their trial setting, it was taking up to 33 days median, sometimes longer, sometimes shorter for the results to come back. Liquid in their trial was coming back in 11 days. This is from, 3 years ago. The same companies are now giving us the results back within 6 or 7 days. So this is where it can fill the void. And also remember, often cholangiocarcinoma gets bucketed with other cancers. You can see cholangiocarcinoma failure rate is higher than your average colon cancer patient where the biopsy is difficult. So this kind of technology in terms of helping fill the void is more relevant for patients with cholangiocarcinoma or lung metastases, where you can see in actual trial settings where they were like, let's compare it head to head. Liquid identified 20% more people with actionable findings in some of these different studies. And you can also see, talking about opportunities for increasing precision medicine, their clinical trial of accrual to precision medicine-based therapies exponentially went up to 4 times once they started doing liquid as well. You know what I mean? So it's useless piece of information if you don't act upon it. You know what I mean? If you have a patient with FGFR2 fusion or MSI or whatever actionable markers, but if you don't act upon it, that information does not help in any ways. In fact, some of these patients who have these actionable markers, there's data to show that chemo actually doesn't work as well for them. So they even do worse than your average patient who may not have these actionable findings. So with that, you know, I'll pause and stop here so we could you know, look at some questions. And while Melinda looks at some of the questions, I just wanted to kind of show one more slide about early detection. And often people don't talk about cholangiocarcinoma, but this is like a multi-cancer early detection assay that's not commercially available. Often you'll see the term called MCED. There's actually a bipartisan bill at Congress right now asking for this test to be covered. And again, you know, the study was called the GRAIL study, as like having a holy grail for a cancer test to detection. Not surprisingly, one size doesn't fit all. A test will not have the same amount of sensitivity for every single type of cancer. For some cancers, you know, this is all in public domain. For like thyroid cancer and stuff, the sensitivity was extremely poor, like 0%. Whereas some of the GI cancers, and see where cholangiocarcinoma is, you know, people don't talk about cholangiocarcinoma as much as we should. It's having the same test is having sensitivity higher than all these other tumor types that are going crazy about these kind of tests and trying to bring it to the clinic. But see who is at the top. It's your cholangiocarcinoma patient. Who's the next to the top? It's your unknown primary, which I can bet, you know, 2/3 are your cholangiocarcinoma patients again. So the top 1, the top 2 is our patients with biliary tract cancers who could benefit from such kind of an approach.
That would be great to have an early detection test used widely. All right, so I invite everyone, if you have questions, to stick them into the chat or the Q&A box. And I will get to a few of these first ones. What might explain a situation where tissue and liquid biopsy identify totally different mutations? Are there situations where a positive liquid biopsy might not indicate cancer?
Yeah, so discordances happen all the time, and no 2 tests would be alike. Even different liquid biopsies may give you not exactly identical reports. However, the main crux would be similar. I think the key about liquid biopsy is you want to do it at a time when shedding is going on. So the ideal time to do liquid biopsy, the reason why liquid biopsy has a bad name is often it's done when somebody is told that the tissue biopsy wasn't enough, now they do end up doing liquid. But then what has happened in the real world is both as a patient as well as a doctor, that person has started treatment. Nobody waits for weeks or months for the genetic test to come back. But when you start somebody on therapy, you saw how quickly ctDNA clears itself. So when you do a liquid biopsy, no matter how sensitive the test is, if there's no DNA floating around in the person's circulation, how will the liquid biopsy make up the test report? You know what I mean? So you have to do a liquid biopsy at baseline in an advanced or metastatic cancer patient before therapy has begun. And also, depending on the situation, it's possible you may have somebody who had cholangiocarcinoma that was taken out a few years ago, unfortunately now has cancer back in the lungs, and it's only a few spots. You saw that even the same cancer in the same person, the same different location of the body, there's different shedding. So you could have a liquid biopsy that shows a result that's not similar to tissue biopsy, or you could have a false negative. You could also have something on your liquid that is not on tissue, especially after exposure to target therapies. As you saw, these cancers simplistically evolve or change their colors. So a tissue biopsy is only representative of the piece of the cancer that was sent to them. We often have patients who have multiple mechanisms of resistance, as I showed you earlier. Liquid shows like there are 3 or 4 different mechanisms of resistance. Right now, the liquid biopsies don't tell you where it's coming from, but you know, it is very exciting to note that in the near future, not only would liquid biopsies tell you that the ctDNA that was detected or not, they would also tell you that the signal is coming from 75% lung or 25% bone. And that, you know, these are things that are not things in the future. These are things that are already work in progress that is not too far from clinic that might happen. So you could have discordances because these are still different tests looking at different materials. For one, you're sending a piece of tissue. So I think you have to think of it as a Venn diagram. There are going to be patients where there's going to be absolute concordance of liquid and tissue. Especially for mutations, liquid biopsy is easily able to pick up mutations, but fusion sometimes you can miss them. There will be cases where tissue will only identify the fusion or the things and liquid misses it. And then there will be cases where tissue is not able to complete at all. And there are cases where liquid is not able to be helpful, especially when you have low shedders. So it's again, the message is it's not meant to replace tissue. It's meant to be complementary.
Thank you. If one harbors FGFR2 BIC1 fusion and has only been detected in tissue over the last 8 to 10 years, what are possible variables as to why ctDNA over same time frame is always negative, no mutations detected? I've been told this is likely due to being a low shedder, low burden, or just not enough cancer cells circulating throughout the blood, but would love your thoughts and input.
Yeah, if somebody's saying 10 years, I'm assuming they're hopefully cured, so that's the best case scenario. And that's why the liquid is telling you about what the situation is today. And as you use the term low shedders or low volume disease, again, the field of liquid biopsy is right now, I think it's important to understand what a false negative means. So a negative report could mean two things: A, that you're cured, or B, there's not enough materials available. Now, I've also had patients with different platforms where some platforms were able to pick up the fusion, and I know that the person has fusion, but the repeated tests, even the case series that we published on the FGFR fusion that's available online, at the time when we published it, of 4 different platforms that I had patients that followed me at different institutions, where different institutions had their own commercial specific vendor, where the same patient had testing through different platforms, where some platforms picked up the findings and some didn't. I would say the other thing to important to realize is even the same platforms have evolved over the years, where some of the results today of a different platform may not be the same even a few years ago. 2 weeks ago, we presented a poster at ASCO about FGFR2 fusion detection across all cancers, including cholangiocarcinoma, using one of the platforms. And as the question talked about FGFR2 BIC. So BIC is one of the partners. FGFR2 could have dozens of other partners. There's something called like baiting the fish. Now, if you know what partners you're looking for, the same liquid biopsy can work better. So technologies are improving. No two technologies are alike. It could just be a shedding or a cured issue, or it could be a testing issue where a different platform may identify the aberration.
All right, thank you. What does MSI stable mean, and is this good or bad?
So the MSI stable, mismatch repairs to deficiency, MSS. So what is being talked about here is there is a syndrome called Lynch syndrome that makes these tumors have a trait which makes them very responsive to immunotherapy. There are something called mismatch repair proteins. So as your DNA simplistically develops spelling mistakes, your mismatch repair, when there's a mismatch, it's able to repair them. The same thing, whether it's present or not, can be detected through multiple tests. So somebody could be mismatch repair deficient under the microscope, or MSI high, or TMB high. These are all trying to talk about the same thing, but through different lenses. And if anybody has any of these findings or is MSI high, they now have immunotherapy as an option, and immunotherapy works gangbusters for them. Unfortunately, in cholangiocarcinoma, the odds of having MSI high is less than 1%. But again, it's not that it's unheard of. This month, I can tell you about at least 2 patients right now with cholangiocarcinoma who are mismatch repair deficient, who are only on immunotherapy and are responding gangbusters. So, and this is the only situation or term where the word cure is being used, even without any kind of surgery and stuff, and even in stage 4 cancer patients. So again, there's no such thing as good or bad. Having any cancer is bad news, but having an MSI high cancer that's not stable, the instability makes the tumor very less responsive to chemo, but the same instability makes it easy to find by your immune cells. So immunotherapy works really well for them.
Right. Are any of these mutations found in extrahepatic cholangiocarcinoma? I only heard ICC mentioned. So do you want to touch on the ones that are more common in extrahepatic?
So the FGFR2 fusion in IDH1 is an intrahepatic phenomenon. Again, you can still have it in extrahepatic, but it's more mainly in intrahepatic. But HER2, for example, it's actually a purely an extrahepatic phenomenon. There are some patients with intrahepatic who have HER2, but gallbladder, some series are anywhere from like 30 to 50%, depending on which series from which part of the world. Even extrahepatic cholangiocarcinoma from Asia and US is different. The BRAF we talked about, MSI high, I don't think has a preponderance for any one of the two. So while FGFR2 and IDH1 is an intrahepatic phenomenon predominantly, the others are spilled across like BRCA or breast cancer related genes. Some of the other fusions or MET or BRAF or BRCA, they are, and HER2 in particular, it's a spectrum. So they're kind of spread throughout. And as we get more drugs, there will be more options for extrahepatic as well. I think at this point in time, both extrahepatic and intrahepatic have, an almost an equal chance of finding something actionable, maybe not the same drug, but a different kind of drug.
Okay. How often should patients be doing a liquid biopsy? Is it ever too often or not often enough?
It boils down to insurance and the cost of society and what is reasonable. At least at baseline, I think it's always of value. I think these are missed opportunities once you start treatment and then you don't have tissue that's insufficient. We have patients who are on blindsided therapy for months and we never have information regarding what they have, and now we're trying to get tissue. And when you start therapy, even the repeat tissue is not helpful because the amount of cellularity, the amount of the cancer that's alive, which is a good problem, starts becoming dead. But the same tissue testing also needs a density of cancer sent to them, no matter how big the surgery or the biopsy is. So at baseline for sure, and for patients on targeted therapy, at any point in time there's progression or there's concern that there's some things that are worse, I think that those would be opportune times to at least consider the liquid biopsy that's meant for NGS testing or the broad one. But then the MRD testing liquid biopsies that are different, that are tumor informed, the ideal time is after surgery, but before starting chemotherapy, and then in the surveillance setting when you are quote unquote in your survivorship and you are trying to see if there's any leftover cancer. It could be potentially as an adjunct to imaging, for which we still need to get more registry and data, but that's where the broad applications of liquid biopsies are.
Okay. What do you recommend if extrahepatic liquid biopsies are coming back negative or unactionable and tissue biopsy is difficult?
Think that if both are challenging, then you have to repeat both at some point in time. It's not uncommon to have both tests being unrevealing, and sometimes that's a good problem because there's not enough cancer and it's advanced, but it's not metastatic. So a good endoscopic ultrasound biopsy, and especially if it's a ultrasound-guided liver biopsy, often that's enough to get enough tissue. But the key is to do it at a time when therapy hasn't begun, or if therapy has begun, to wait for the time when unfortunately the treatment stops working.
Okay. Is it going to be plausible to have ctDNA tracking done while a patient is on targeted therapy when waiting for imaging to find gross disease?
Yeah, and I think that's the whole kinetic story in the article that we talked about. That's where companies, as well as patients, as well as providers, as well as clinical trials, are trying to, because the half-life is so short, it's a great biomarker as opposed to CA19-9 or CEA. Those are protein-based markers, and also they can be falsely high in patients with obstructive jaundice from cholangiocarcinoma, so they are not great in terms of specificity. So because the shedding and the half-life of ctDNA is so short, as early as 2 to 3 weeks into therapy, somebody could assess response to not just targeted therapy, even to chemotherapy or immunotherapy. And there's work by us and other colleagues presented looking at as a marker predating to response or progression. We've had instances where the imaging was kind of confusing and maybe things were worse, but were not worse. But then you did a liquid biopsy, and it clearly showed that when there were new resistance mutations, that actually helped in clinical decision making in some of our challenging patients on cholangiocarcinoma, some of which were on trials that we actually were comfortable in taking them off the trial, even though they didn't meet the criteria of whatever percentage growth that happened. But if the same patient that I showed the cartoon of is that had 4 different resistance mutations, you don't need a scan to tell you, or you don't need to waste your time on a drug that has stopped working anymore. So this is where this can be helpful both in terms of clinical trial as well as clinical care.
This is a personal note to you. Great to see you again. Thank you for taking interest in my wife's case 3 years ago. I will be forever grateful to you. Keep up the great work. If a report comes back as insufficient tumor, is retesting an option?
Yeah, retesting on another specimen. So again, it depends on what was sent to them. So sometimes, unfortunately, what was sent to them, that was all there was left to it. But sometimes, it's a surgical specimen, meaning that, and it's also possible you need to kind of look back at that report and see what was sent. A patient might have had more than one biopsy at more than one institution. A person might have had a biopsy and a surgery. So I think it's important to kind of go back to the report and see what was done. And also, I think what's also deceiving is we had a patient recently where the report, for example, said, that we didn't find any mutations, didn't say insufficient tissue, but in the footnote said we didn't do RNA because there wasn't enough tissue, but they just had the DNA report spelled out. Now we had to, fast forward, get tissue because we thought, we might be missing a fusion for which an RNA would be a better test, and the liquid actually didn't pick up anything. So both liquid and tissue were unrevealing. But then, we persisted, and actually the patient also, thanks to her patience and flexibility, we had to have actually 2 biopsies because, again, the second biopsy was also not enough because this was a lung cancer metastases. And then third time was a charm, as they say. And then the RNA actually picked up a rare BRAF fusion. While the patient wasn't responding to any kind of, chemo, and then we were able to, find a trial for her off label. We were able to also give her a MEK inhibitor, and that response was, unprecedented compared to the chemo. So that's where I think it can be helpful to, still be persistent to, not go crazy. But I think it's one of those things that you want to really give due time and effort to find a report for, at least for cholangiocarcinoma report that says that they found mutations. In fact, a bland report, simplistically speaking, makes me wonder that you might be sitting on a fusion or something actionable that the testing missed, and you might need to repeat a test with a different test company or a broader test or a liquid, or you need to do it on a different sample.
Okay, a couple more questions. Have you seen any successful reversal of the FGFR2 V564L resistant mutation discovered on liquid biopsy?
Yeah, no, so some of the cartoons and stuff that I showed earlier, these were all patients where, not with fancy drugs, just with plain switching out chemo or doing something different, genetic, like radiation or ablation or Y90, or these patients, they lost their they lost their resistance mutations after being off of target therapy, just like the cartoon I showed earlier, where doing something non-targeted, you can kind of quote unquote resensitize the clock. So while there are some resistance mutations for which a new drug can overcome, the mechanism, as you can see here, not just the 564L. Again, a cancer doesn't read books; it can acquire any of the spelling mistake. But you can see in these 3 different patients, like this second patient had this specific 538L mutation that was the resistance mechanism. The case number 3, for example, the same cancer actually had 3 different mechanisms, and with just genetic chemotherapy and just taking a break off of target therapy, these mechanisms disappeared. So we were able to reuse or move on to a different FGFR inhibitor. The same patient, case 3, had, in fact, all these 3 patients of mine that are shown here, they all had at least 3 different FGFR inhibitors during their journey with cancer, all giving some mileage for a certain period of time. And this is even before some of these new drugs came out, where they can, you could go straight to the other drug, but if you don't have the opportunity of going to a newer drug that can overcome the resistance mutation, just not messing with the beehive and letting the dust settle, these mutations can disappear and fade over time. And I think that's where, as one of our colleagues, Dr. Schroff, puts it, you got to spot weld as well. If everything is steady and there's one lung nodule that's growing, maybe that's the lung nodule which is not behaving, that you could just zap or radiate or even resect. And again, case by case, local regional therapies are not out of bounds in these patients with resistance mutations on target therapies.
Okay, 2 more questions, I promise, and then I'll let you out of here. Could you elaborate a little on VAF percentage, and is this important data and or info to have in regards to treatment decisions or from a disease standpoint? In other words, in layman's terms, what does VAF percentage tell us if noted on resulted report?
VAF is the same thing that I was talking about earlier, that 100% of your blood should be your own blood, 0% should be tumor DNA. So the VAF is something called the variant allele fraction. Simplistically, what it's saying is, in the DNA that was sent in the blood sample, how much of it was actually tumor? The correct answer should be, or well, the hope should be that it should be 0% VAF. But unfortunately, of course, somebody has cancer, so they have some circulating tumor DNA. So the average is actually 0.2% or so. But again, sometimes that comes across as low. Well, the low is that number should be 0. So anything detectable is not a good sign. Now, studies have shown that somebody who has a very high VAF has a lot of cancer in their bloodstream versus somebody who has a very low VAF. So of course, you don't have to be an oncologist to realize that having a low VAF is a good thing. But I think for the individual patient, it's more so the trend over time. Even if somebody has a high VAF and with therapy that goes down with the kinetics of response to therapy, then that's more of a dynamic marker. It's not a static variable that you can't change forever. So then, it depends on what is driving the VAF. Is it an FGFR fusion or an MSI high tumor that you can give something really actionable to, versus something that you may not have drugs and options, and that's a bad prognostic sign for that patient, unfortunately.
Okay. Is liquid biopsy effective for ascites fluid or for bile fluid?
That's a great question, and that's something that I keep pushing the companies to, look for, because liquid biopsy, broadly speaking, right now we talk about liquid biopsy in the context of blood, but it's not just blood, it's fluid. It could be acidic fluid, it could be pleural fluid, it could be bile, it could be urine. Bile is a gold mine because that's where the source is. So you can, these same technologies, and we also looked at peritoneal tumor DNA and pancreatic biliary cancers, and that can pick up cancer before the blood can pick it up. So the practical issue right now is apparently it's more of a legal issue that the same companies that have finalized their test for tissue or liquid, you can't change the medium of what's being sent to them. But already in brushings and liquid, there's published data from different groups in Europe as well as here that bile duct can actually give you more information than the blood of the same patient, because shedding is a problem here as well. So it's a great question, and it's a great option. It's just a matter of time before we have dedicated tests that our colleagues in GI would be doing it at the same time that they're doing the brushings. They might send some fluid while they're there for so it will be something called bile tumor DNA as opposed to circulating tumor DNA.
Good. There's 3 questions left, Dr. Kazi. Do you want me to answer them, or can I send them to you? Okay. So is KRAS and CDKN2A, are they still identified with liquid biopsies? Are those easily identified?
Mutations are very easy to identify. CDKN2A is a large gene, so sometimes you can miss it, but KRAS is easily identifiable. And also in the world of actionability, KRAS G12C, the undruggable KRAS is now becoming druggable. So we have several G12C inhibitors now, including data in pancreatic biliary and cholangiocarcinoma malignancies that patients have had responses to. The same companies that have the G12C and now have G12D inhibitors, and G12D is not an uncommon problem. Just a few weeks ago at ASCO, we presented data regarding a KRAS vaccine, which targets DRV, SAC. So these are also relevant. And also in the context of CDKN2A, there are clinical trials that are looking for patients with CDKN2A. So not in the clinic, but identifying, these mutations are helpful in identifying the right trial for the patient.
Okay, I'm going to ask these last two questions together because they're similar. I think I heard at the CCF conference that Illumina liquid biopsy was much more likely to pick up FGFR2 fusions. Am I recalling that correctly? And also, is there a company you prefer to use for liquid biopsies, such as Garden 360, et cetera?
So I have worked with all these companies. Illumina was one of the posters at the Carcinoma Foundation conference, and one difference between Illumina and some of the other companies like Garden or Foundation or Tempest or whichever platform, it's often, the choice of platform, surprisingly, it's not the provider, sometimes it's the institution. Certain institutions, for whatever crazy reason, just prefer one vendor, and certain times certain doctors prefer just one platform, so it's easy to keep track of reports, otherwise it's all over the place. So I don't think there's one preferred vendor here. The difference between Illumina and some of the other platforms is Illumina is like the machines and the companies that some of these same companies are actually using some of these machines as well. But then Illumina is decentralizing some of these capabilities. So a lot of the hospitals like Cornell and Iowa and some of the other hospitals, they use Illumina's machines to do testing in-house. So, as opposed to it being a send out, some of these tests can be developed or be available in-house. So that's the Illumina data, but of being able to pick up FGFR2 fusions. But again, the papers that I showed, the first paper was with one company, the second paper was another company, the poster I did was with a third company. So I think I don't have a preferred vendor. I think it's good to have options. It's actually good to have competition too. It keeps everybody on their toes and everybody is striving to get better. And also, like I said, one important message is not that even within the same vendor, the same assay, even if they have published data from 2 years ago or even a year ago, their platform right now is different than their platform before, which means it's continuously improving. I think it's a good problem. I would leave it at that. Yeah.
That's wonderful. Thank you so much. This was a great information and a resource that I'm sure we'll use for a long time. We appreciate your time being here and taking the time to present and teach us. And thank you all for joining us. Everyone have a wonderful day. Thank you.